Welcome, Vasudha madam.
Oh, thank you.
Doctor, we are live now.
Yeah. Dr. Archana, you can give your first introduction.
Yes, okay. So good evening to everyone who have joined. So the first question which stares at all of us is why women in ophthalmology? Well, women ophthalmologists, no doubt, they are the majority in our fraternity. But how many women are in the front line? How many of them are considered forces to reckon with? And how many of them do you see in limelight, participating, deciding? This is not a forum which is blaming anyone. Women, however, face barriers, some which are imposed and some which are self-built. And for the first time in many years, we have a president who genuinely understands this, and she has chosen to support women, not just on paper, but through her actions, which I'm sure will quieten all the background noise. And what perfect timing! Navratri is that time of the year where feminine energies have a natural upsurge. So without much further delay, here to Madam President.
Thank you, Archana. That was a wonderful introduction about women in Tamil Nadu. This question has been there in the minds of almost all men. Why should we have anything different? But like Archana said, I think we need more representation. And just to make sure that those people who are left behind, who are extremely good in their work, but they're not given the opportunity, we should help them along and make them shine. And I think one standing example is Vasanta Madam. She's been a source of inspiration, a great teacher, and she's always stood her ground in everything. So I think with her as a chairperson and a co-chair, Kalpana herself has got so many students, a wonderful legacy both of them have. And Dr. Sharmila is now one of the great teachers. So we're going to have an excellent session. I request all of you to keep up the timing. And one more thing, this is not going to be the first. We're going to have a couple more sessions, at least in this year. We're planning to go for few more sessions. And with this, without much ado, I'd like Dr. Vasanta, Dr. Kalpana, Dr. Sharmila, and Dr. DC to say a few words before we start the program.
Thank you, Dr. Sujata, for starting this program. I think you must be given another Nari Shakti award for this. I'm very happy that you have started this.
Thank you, ma'am. Thank you.
So, and it's a very wonderful initiative, madam. We are all really proud, and I think this will help a lot of women in ophthalmology to come forward and exhibit their talents.
Yes.
Thank you so much.
Dr. DC?
My most respectable seniors, my teachers, my friends, and my students here. It's really honor to be here with among so many women. I feel a little odd only, but I think I see 80 to 85% of my postgraduates are women, and it is really going up. And they have to be in the forefront and the leadership and be equal, if not better. I'm wishing all of you all the very best for this wonderful program. Thank you, madam.
Thank you. Thank you. Dr. Sharmila? You're muted. You're muted. We're not able to hear you.
Can you hear me?
Your voice is very low.
Yeah, voice is low.
Ma'am, you can continue, ma'am. I'll join from the phone later. Ma'am, you can continue.
You are muted, Sharmila.
No, ma'am, my voice is not audible. I'll join from
Oh,
the phone later, ma'am.
Okay. Kalpana, can we start the program with the...
Yeah, we'll start with the first presenter, Dr. Mahalakshmi, with the topic, a case of probable VKH. Yeah, Dr. Mahalakshmi, you can share the screen now.
Yes, ma'am. Good evening, ma'am. I'm audible, ma'am?
Yeah.
Yes.
Go ahead.
Ma'am, I thank President ma'am and all the senior most faculties and my respected teachers for giving me this opportunity. It feels very happy for me for taking this initiative since to empower the women in TNOA. Thank you for giving me this opportunity, ma'am. And can I start my presentation, ma'am?
Yeah,
Yeah.
please.
So it's a case of 28-year-old man, fisherman by occupation, came with the complaints of defective vision in the both eye for the past 15 days. There is no history of any ocular trauma or surgery, no history of any systemic illness. His best corrected visual acuity in the right eye was 260 NIG/NIP and left eye 160 NIG/NIP, and both eye near vision was N36. Intraocular pressure was normal and fields and color vision were defective. So slit lamp examination of the anterior segment revealed fresh KPs on the back of the cornea with cells and flat, pupil ill sustained and lens clear. So this was the fundus examination of the right eye, which showed optic disc hyperemic with edema with multiple serous elevation over the posterior pole and over the macula with macular edema and the ILM folds. So the same was in the left eye fundus also. So we proceeded with the OCT, which showed folds of RPE with subretinal septate and the subretinal fluid. So at this point, a young man with a bilateral serous exudative RD with no history of any trauma or surgery, the possible DD will be inflammatory cause, VKH, posterior scleritis, and infectious choroiditis. So we proceeded the patient with furthermore investigation, of which B scan revealed diffuse choroidal thickening with serum ACE negative, MON2 negative, and RA factor was negative, VDRL was negative, thus ruling out all the infectious choroiditis cause. So we proceeded with FFA, which revealed multiple hyperfluorescent dots in the arteriovenous phase and multiple hyperfluorescent dots in the venous phase suggestive of starry sky pattern, which is the pathognomic of the VKH. There was also subretinal pooling of the dye in the late venous phase. So we came to the diagnosis. It's a case of bilateral acute granulomatous panuveitis in active stage. The cause will be Vogt-Koyanagi-Harada syndrome. So we started the patient with IV methylprednisolone on 1 gram per day for 3 days, followed by oral steroids. The patient was put on maintenance therapy, oral azathioprine. And during the follow-up, the final visual acuity attained was right eye 6.9 and left eye 6.12 with pinhole improving to 6.9 with both eye near vision N6. So this was the OCT following the treatment where there is a resolution of the subretinal fluid and undulations and everything was finally resolved. So VKH, it is an acquired autoimmune disease involving T-cell mediated hypersensitivity to the melanocytic self-antigen with underlying genetic predisposition and possible microbial trigger or cutaneous injury. So it involves 4 phases, which include prodromal, acute uveitic, convalescent, and chronic recurrent. In acute uveitic stage, we have bilateral granulomatous anterior uveitis with multiple serous RD, optic disc edema, and thickening of the posterior choroid as present in this case. In convalescent, we have skin and uveal depigmentation with the resolution of exudative RD and sunset glow fundus. Recurrent stage usually present with repeated bouts of infection, glaucoma, subretinal fibrosis, and choroidal neovascular membrane. So this is the revised VKH diagnostic criteria, which involves no history of penetrating ocular trauma or surgery, no clinical or lab evidence suggestive of other ocular disease, bilateral ocular involvement with evidence of diffuse choroiditis, FFA features, and ocular depigmentation, neurological or auditory finding, and integumentary findings. So when all these 5 criteria are present, we name as complete VKH. When 1, 2, 3 with either 4 or 5 present, we call them as incomplete. And when 1 to 3 criteria is present, we call them as probable VKH. Since this patient has 1 to 3 criteria, we named it as probable VKH.
Mahalakshmi, can you just tell the take-home messages? Yeah,
yes,
and final points. Yeah.
Yes, ma'am. So the final bites is like early treatment is necessary for the successful management of the VKH. It's very crucial to treat within the therapeutic window of opportunity, mainly within 2 to 4 weeks. Enhanced depth imaging OCT, it plays an important role in diagnostic and monitoring the disease activity. So ICGA is superior to EDI OCT in identification of the subclinical lesion. Blue light fundus autofluorescence and OCTA were essential in documenting the secondary evolution of the disease. It's very essential in early initiation of the immunomodulator therapy to achieve the disease control and prevent the progression of the disease to the chronic stage and also to prevent its complication. So these are my references. Thank you, ma'am.
Thank you, Mahalakshmi. So the entire, this webinar is to bring many women into spotlight. And Mahalakshmi is one young, energetic speaker from RIOGO. She just finished her MS. That was a wonderful presentation, Mahalakshmi. We'll just
Thank
move
you,
over
ma'am.
to Hemapriya for the expert comments. Hemapriya is an assistant professor in RUGH.
Thank you for the opportunity for presenting this case. Good evening to one and all present here. And this was a 28-year young male who presented with a acute bilateral granulomatous anterior uveitis. And all the investigations, initially we had a differential diagnosis of inflammatory uveitis, other infectious uveitis like tuberculosis and syphilis were also our differentials, and posterior scleritis and other due to systemic diseases were considered. And on investigations, all the infectious uveitis were ruled out, like it was negative for tuberculosis and syphilis. And the patient had no history of ocular pain, on especially on ocular movements was absent, which is suggestive of posterior scleritis. And B scan also, though the T sign on B scan, which doesn't rule out posterior scleritis, which was absent in this case. And also in the OCT of this picture had a classical presentation of the subretinal fluid accumulation with the septate, which is due to the disruption of the basilar layer, which is a classical of VKH in this patient was present. And the FFA also had a initial pinpoint hyperfluorescence in the early arteriovenous phase, and late pooling was of dye, and a starry sky pattern was there, which is also classical of VKH. And though the patient have no other extraocular manifestations like skin manifestations and auditory manifestations were absent, it could be an acute uveitic phase of probable VKH was diagnosed, and the patient was treated with the IV methylprednisolone and followed by oral steroids, and the patient responded well. And for the long-term control of the choroidal inflammation, we have started on the immunomodulator therapy. Azothioprine also was started for this patient, madam. And the patient had improved well with the initial presentation of visual acuity 2/60, and the 1/60 was improved in the right eye of 6/9 and 6/12 in the left eye. And the patient
that was
is on
a dramatic
regular
improvement, and even the OCT showed a very good significant improvement.
Yes,
So you work in conjunction with the rheumatologist.
Yes, ma'am. Rheumatologist opinion was obtained, and pulmonologist and all other opinions only. After infectious uveitis and everything was ruled out, and then only we have started the patient on steroids, and he responded very well, and he's on our regular follow-up, and he's doing well. And
thank you, Dr. Hemapriya.
Thank you, ma'am. Thank you.
Vasanta ma'am and Kalpana ma'am, can we have your comments, please?
So the patient is on, now what is the patient is on?
Both a dual therapy for steroids on tapering dose, and the patient is on immunomodulator therapy of azothioprine, ma'am. And regularly he is on LFT test, and the patient is on regular follow-up.
Yeah, how long you're planning to continue? Because you have to continue for a longer period, right?
Yes, ma'am.
Otherwise,
for at least 6 to 12 months, and we get other opinions also. And periodic 6 weeks we do a liver function test and other CBC also, considering the side effects. Also, we do periodically, and the patient is doing well, ma'am. We are planning up to at least 1 year if needed, ma'am.
Yeah.
And
yeah. So long-term follow-up is needed for this patient.
Yes. To prevent the chronic
excellent
phase.
results. Excellent results.
Yes, ma'am. Thank you. Mm-hmm.
Vasanta ma'am, do you have anything to add?
Okay, they've done a very good job. The vision has improved from 2/60 to 6/9. That's great.
Yes, ma'am.
Thank you very much, Dr. Hemapriya and Dr. Mahalakshmi, for the wonderful presentation.
Thank you, ma'am.
Can we move over to the next presentation by Dr. Manjusha? Manjusha, can you have your presentation?
Yes, Manshal, I'm sharing my screen. Is my screen visible, ma'am?
Yeah.
Very warm good evening to one and all. I'm Dr. Manjusha, working as a senior resident in JIPMER Ophthalmology, Department of Ophthalmology, JIPMER. And today I'm here with my moderator, Dr. Nirupama Kasturi, ma'am, to do a case presentation on a puzzling orbital mass and subro approach to supratemporal orbital lesions. So here we have a 34-year-old male patient hailing from Pondicherry who came with the chief complaints of drooping of the right upper lid since 3 months. Coming to his history of presenting illness, it was insidious in onset, gradually progressive and painless. There was no history of variability in degree of drooping like any diurnal variation, or no history of double vision, no history of any trauma or loss of appetite or weight loss. And coming to his past history, there were no similar complaints in the past, and patient had no systemic comorbidities, and his personal and family history was also normal. And the patient was conscious and coherent, oriented to time, place, and person, and his vitals were also stable. Coming to ocular examination, his head posture was normal. Face was asymmetrical due to the ptosis, and the ocular position on Herzberg corneal reflex test is central. And upon checking the ocular movements, there was limitation of elevation in the right eye. So this is a picture showing the 9 cardinal gaze positions of the eye. We can see there's limitation of elevation in dextro elevation, sursum elevation, also in levo elevation, whereas all the extraocular movements, other extraocular movements are fine, free and full. Upon proptosis evaluation, on inspection, there was mild proptosis and infromedial dystropia in the right eye. There was fullness of the right orbit superolaterally, and upon palpation, there was no warmth or tenderness, and a firm mass was felt superotemporally, and resistance to retropulsion was present. There were no thrills or pulsations felt, and on auscultation, there were no bruit were heard in both the eyes. And we did a proptosis measurement using Hertz, and in right eye it was 22, and in left eye it was 21, and there was a dystopia of 4 mm inferior and 1 mm medial displacement of the right eye. And coming to the ocular examination, the visual acuity in the right eye was 6/6 and color vision was also normal. There was a supraorbital mass and moderate ptosis with moderate LPS action. And the other anterior-segment findings were normal, within normal limits. And also the lacrimal sac area was normal, lacrimal puncta was patent, and the IOP was 14 millimeters of mercury with NCT, and the fundus was within normal limits. In the left eye, the anterior segment findings and also the posterior segment findings were within the normal limits. And coming to the summary, a 34-year-old male patient came with the complaints of progressive drooping of the right upper lid since 3 months. He had moderate ptosis, mild proptosis, and infromedial dystropia, the normal anterior segment and fundus examination. And all these were suggestive of right eye abaxial proptosis. So our provisional diagnosis was right superolateral orbital mass with differential diagnosis of hemangioma, schwannoma, dermoid, and pleomorphic adenoma. So we did an NCCT of the orbit, and it showed an extracorneal mass which was well defined and homogeneous mass superolaterally near the lateral wall. Coming to its extent, and the mediolateral extent was 1.6 centimeters, and the anteroposterior extent was 2 centimeters, and craniocaudal extent was 1.3 centimeters. There were no bony erosions, and it was discrete from the lacrimal gland. So we did a surgical management with the right eye superior orbital mass excision we did with the general anesthesia using the subbro and subperiosteal approach. So intraoperatively, this mass looked like a dermoid, but upon histopathological examination, it was a pleomorphic adenoma with squamous metaplasia. So these are the histopathological pictures of the mass. So we called the patient for review after 1 week. We could see improvement in the proptosis and also in the extraocular movements. And the patient was advised for regular follow-up to check for any recurrences. Thank you.
Thank you, Dr. Manjusha. The orbit is a Pandora's box and you proved it again. We move over to Dr. Nirupama ma'am for her expert comments.
Yeah, good evening. So this was an interesting case because it was a young patient who actually came with complaints of ptosis and he was not aware that there was a mass in the orbit. And on examination, the proptosis was very mild, only 1 mm proptosis and more of infromedial dystopia. So the mass was actually in the supratemporal orbit, and clinically and radiologically it appeared like a benign, well-defined tumor. We had suspected anything like a hemangioma, dermoid, or a pleomorphic adenoma. And since FNAC is contraindicated in pleomorphic adenoma, we actually went for the excision biopsy. Yeah. So the excision biopsy, when we did it, intraoperatively, it was appearing like a dermoid. The surface was irregular, it was well defined and encapsulated mass. And 100% I thought the histopathology will show a dermoid, but it actually was a pleomorphic adenoma. And usually the approaches to supratemporal orbital masses, it can be either through a lid crease approach or transconjunctival via the superior fornix. But this can cause damage to the levator and result in post-op ptosis to the patient. Other approaches are you can do a full thickness vertical lid split and approach the superior orbit, or you can also do a lateral orbitotomy and do the approach. But these are more difficult and require more expertise. But we opted the subperiosteal approach where we make the incision just below the eyebrow And once we separate the periosteum from the superior orbital margin, we can make an incision on the periosteum and we can actually reach the tumor. And we can dissect it and excise it in toto. And if the tumor is very large and we require more space, we can actually use a bone drill to drill the superior orbital margin and cause a little excavation and also deepen the space to reach out the mass. So this approach we have used for 2-3 patients when we have found that it's a very simple and safe technique to reach the anterior orbital masses. And this patient, luckily we could excise the tumor in toto, and the post-op outcome was also good. And since it showed squamous metaplasia in the histopathology, we have also warned the patient that there is a risk of recurrence, and we are keeping him on regular follow-up.
Thank you, ma'am. That was a wonderful outcome. Vasanta ma'am and Kalpana ma'am.
When I was in Stanley Medical College just for 1 year, I have done orbitotomies. Those days we used to do everything from cornea to retina, everything we used to do. And it was the first time orbitotomies were done there. I've done 3 orbitotomies and entropion, ectropion correction, all those things we have done there. That is just, I'm just telling this to say that we women can do anything.
Yes, ma'am. But now actually we are moving on to minimally invasive approaches, ma'am. I think Dr. Pratibha also, she is
Yeah.
oculoplasty surgeon. She can just add her
Dr.
comment.
Pratibha, you want to come in?
Nice presentation and thank you for the inputs, ma'am. Yeah, I usually do along the lid crease. So I made a lid. The only disadvantage with the subbrow, what we feel is that scars sometimes might be evident for people who might not want that thing to be there. So with lid crease and just going under the orbicularis, we can reach the periosteum easily. That is how I do it for the orbitotomies which I want to go through superior and or to remove lacrimal gland masses. Apart from that, everything, your points are well taken, ma'am. Thank you.
Just one question from my side. Madam, after removing the mass, you're subjected to histopathology. And they're supposed to have a pseudo capsule, right?
Yes.
And it has to be intact. And did the pathologist report like it was intact? Because any evidence of disruption means bad prognosis, and chance of malignant transformation is much higher. So did they report that also?
Yes,
Like
ma'am. I don't.
intact pseudo capsule. That's the only thing
Yes,
I
ma'am.
wanted to know.
Yes, ma'am. They have not reported, I think, ma'am, but maybe we'll convey this to the pathologist so that
Yeah.
we can
Any
ensure that
breach in the pseudo capsule carries a
since
risk.
intraoperatively we could excise it in toto,
In
we
toto.
didn't think about it, but we will put across to our pathologist, ma'am.
Yeah, they have a better visualization of this pseudo capsule.
Yes, ma'am.
Thank you very much, ma'am, for enlightening us about the different approaches. Can we move to the next case, Dr. Bala Saraswati?
Yes.
It's going to be a video presentation on a complicated cataract case. Dr. Bala Saraswati?
Hi, 1 minute. I'm just
If there's any glitches, can we move to the next presentation by Dr. Srimati Narayan?
Sharmila, can we move on to the next speaker?
Can we have Dr. Srimati Narayan?
Yes, ma'am. I'll just share my screen.
Rajkumari ma'am is there? Yeah. Yeah, we just started screen sharing.
Visible, ma'am?
No, it hasn't started, is it? Rajkumari ma'am, you want to come in before she starts?
Yes,
Is
Shamila.
my screen visible?
On the outset, I'd like to thank TNOA ARC and Sujata Madam in particular for giving this opportunity for Dr. Srimati. Actually, this is a just an art video. I know. This is a case of actually a 19-year-old girl. Actually, we were called upon. It was a call over only. It was an emergency from neurology department with a girl having continuous fits and almost unconscious. She had been recovering from her this thing. I think she has started. Shall I talk later or?
Yes, ma'am. Yes, ma'am. She can continue with the presentation.
She can continue. Okay, okay. I'll talk later.
Okay. Is my screen visible, ma'am?
Yes, yes. Yes, please continue.
Good evening, ma'am. Thank you for the opportunity for Dr. Siddhartha, ma'am, and the TNOA team. I'm Dr. Srimati, working as a senior. Yes, ma'am. I'm Dr. Srimati, working as a senior resident in Chettinad Medical College, and my moderator today is Dr. Professor Rajkumari, ma'am. And this is a case of posterior reversible encephalopathy syndrome. It's one of the rare cause for reversible blindness. So actually, I'd like to give some introduction about the posterior reversible encephalopathy syndrome. It is a rare neurological disorder usually present with seizures and visual disturbances, especially in young females. And the patient usually presents with rapid neurological symptoms, and usually the diagnosis is mainly by MRI. There are two main theories for the pathogenesis. First one is the failure of the cerebral autoregulation in sudden acute hypertension, and second one is endothelial dysfunction directly by the toxins or by the any chemotherapeutic drugs in autoimmune diseases, and it usually causes cortical blindness in 39% of the patients. And generally, this patient presents with normal ocular examination findings. Pupil, fundus, everything will be normal. And the diagnosis is usually in MRI. In MRI, the classical findings are it shows hyperintensities in the T2 weighted images that is suggestive of vasogenic edema. And the treatment is mainly reduction of BP. So moving on to the case, we have got a emergency call over from the medicine ICU for a 21-year-old female patient who developed a sudden blurring of vision in the both eyes, which progressed to complete painless bilateral vision loss. And the patient had a history of seizures for 1 day and headache for 1 day and fever, vomiting for 5 days. And initially, she was managed in the medicine department as acute meningoencephalitis with anti-epileptic medications. And on the second day of admission, the patient's BP was increased. It is 160/95. And on the next following morning, she developed a sudden blurring of vision, which progressed to sudden bilateral loss of vision. And there's no history of trauma, no history of similar episodes of seizures in the past. And there is no relevant family or personal history. And she's not a known diabetic, hypertensive, tuberculosis, or epileptic patient. And general examination, the patient was, the patient was lethargic, and she obeyed comments, and her BP is 160/95, and there is no neck stiffness. An ophthalmic examination, her posture was normal, and visual acuity is both sides, it's a perception of light.
Your voice is breaking.
Yes, ma'am.
Can you just move to the slides? That's okay. You just move.
Yes, ma'am.
Keep moving the slides.
So the anterior segment examination was normal. Pupil is normal. There is no RAPD.
and color vision could not be tested because of poor vision, and the fundus examination was also absolutely normal. And so the patient was we investigated the patient. The blood investigations revealed only mild leukocytosis. There is no specific blood positive results, and lumbar puncture showed a hemorrhagic tap and some borderline elevated protein levels, and there is a culture sensitive or negative for both virology, bacterial, and also for tuberculosis. And the MRI showed bilateral parieto-occipital lobe hyperintensity lesions suggest of vasogenic edema. So the diagnosis was made as posterior reversible encephalopathy syndrome, and the patient ANA results showed positive, and other investigations for BP like renin-angiotensin levels were normal, and ESR, CRP, and rheumatoid factor also were normal. And this is a MRI finding of the patient showing bilateral parieto-occipital hyperintensities causes vasogenic edema. And the patient was immediately managed with IV levetral infusion followed by oral nifedipine, and the BP was under control. And after within 6 hours, patient vision improved to 6/60, and over the next 6 hours, her vision improved to 6/12 and right left eye, and 6/9 in right eye. So within 24 hours, she regained her baseline vision. So no further seizures or neurologic deficits were noted during her hospital stay. So summary, it's a case of a 21-year-old female developed a sudden painless complete bilateral loss of vision. Her initial complaints was seizures, and on examination, the BP was elevated, and both anterior segment and posterior segment was normal. And the MRI showed vasogenic edema suggestive of posterior reversible encephalopathy syndrome, and her ANA was positive. So the cause here is the autoimmune vasculitis was determined to be the cause of elevated BP, which led to the press. So diagnosis, it is a case of bilateral cortical blindness. So probable causes posterior reversible encephalopathy syndrome. So in this case, it's because of autoimmune vasculitis, which lead to the acute hypertension phase. Then this leads to the press. So that, and the patient developed a cortical blindness, which is reversed with decreasing the BP. So
Thank you, Dr. Srimati. Can we move on to Madam for comments? That was a wonderful presentation. When you're working in a multi-specialty hospital, you come across these kind of presentations, and I've seen a couple of press cases in OG during OG call-overs.
Yes, ma'am. It's
Okay,
very
eclampsia
common in
eclampsia
eclampsia
cases.
patients.
Dr. Sharmila, Dr.
Yes, ma'am.
Anand is also there. So after Dr. Rajkumari, she can also make a comment.
Yeah.
Yes, ma'am.
Actually, thank you, madam. Actually, in fact, we had never come across this case. We actually thought probably it could be some hypertensive encephalopathy and all. But the thing was, this girl fundus absolutely normal, and it was almost like a cortical blindness, pupil reacting, and all these things. And then only when the radiologist showed us this, this particular thing, it is imaged well in that T2 flare mode only. You can see this. Actually, it is a vasogenic. It is not, because malignant hypertension means it is cytotoxic. That is, it will destroy the neurons. Whereas here, it is vasogenic, means it's mostly the blood supply. It's the auto regulation of the brain. No, that is becoming defective. So this, they say, why it is affecting, and especially it's affecting the posterior cortex, not the anterior. The reason being, posterior part, the auto regulation of the brain is less, which is supplied by the vertebral system. Anterior, supplied by the internal carotid, has got a very good supply. And they say it is eclampsia, and it can be even autoimmune diseases. These things can trigger. But one thing, the radiologist, our neurologist also said, there is an entity in this called as an atypical press. This atypical press, it produces all these hyper intense signals involving almost all part of the cerebrum, frontal region, basal ganglia. So that we should be very careful. This one is reversible. That one, it progresses even to death also. I came across in one neurological journal saying it leads to death. So we have to be careful. But one thing is, we have to do all, because female especially, we have to go in for autoimmune diseases. That has to be investigated. And this girl, she has got ANA. So after she recovers, she'll be sent for to the rheumatologist for that investigation onward, because we don't know, she might get back the same thing. It is reversible. It can come recurrent also. So these things also occur. So we are just waiting for her to recover and she'll come back to us, our department for future. And we also don't know because occipital lobe, we are saying it is affecting the white matter. What if the optic now, what has happened? All these things we don't know. She has to come back to us again and we have to do further investigations.
Thank you, ma'am. Can we have Ambika ma'am for expert comments? You want to add some
Very
points?
nice case, Dr. Srimati, and I think it's well managed also. See, when you see a young female with a bilateral severe profound vision loss, almost going to perception of light and a brisk pupil, we are directly on the target. It's only the occipital cortex. So particularly when a patient, these type of girls usually will have, nowadays we see a lot of young women having chronic headache as a presenting symptom before, because she may be having an autoimmune background, RA, ANA, ANCA, APLA, and sometimes we can have some, we have picked up many gross anemia second to sickle cell disease. And we can also have myeloproliferative disorders. These can be the harbinger for a severe hypertension. And these all are interconnected. So once they go in for that phase, they go for a press. But nice to see your patient has responded very well. But most of the time, the recovery is not that swift as you expect. It takes a long time. An atypical press has a overshadow of a CNS vasculitis. So you have to be very careful because these imaging protocols, as she rightly explained, you need a flare sequence and a properly segmented T2 cuts. Otherwise, we may tend to miss these lesions. It's not only the vision loss, they can be an occipital syndrome, right? From visual inattention to so many other factors can be taking a long time to recover. That's what is my experience.
Thank you, ma'am. Doubt. It is autoimmune, no? So you need not give steroids immediately, is it? Because
It depends on your blood profile, madam, how severe and how much, because most of the times in the initial phase, it becomes like we are controlling like a malignant hypertension. So once we control the cause, then we start prodding about the reason behind this spike in a young patient. It's like finding the secondary causes. Once we come to the knowledge that there is a significant autoimmune overlay, yes, there is a role of immunosuppression. But again, there is a double-edged sword of how severe we can pump their steroids in the early phase where we are struggling to bring their BP under control. So most of the time, I have seen people who are hospitalized with IV labetalol, the BP will get controlled, and maybe after a week or two only, we will start considering the cause for the raised blood pressure or the event which has culminated.
Because I have seen young patients having high blood pressure and just a few cotton wool spots in the fundus, having very grossly reduced. Of course, not like PLPR, like 624, 636 and all that. I have seen cases like that with malignant hypertension. That is why I asked.
Okay. Good case, Dr. Srimati.
Thank you, doctor.
Thank you, ma'am. Can we have Dr. Sindhuja with a presentation? Dr. Sindhuja? That's a nice topic, by the way.
Good evening. Can you all hear me?
Yeah, loud and clear. Yes, go ahead.
So everyone was talking about case reports. So I'm just going to talk about the importance of oculoplasty for general ophthalmologists. So why I feel this is little important is because we do commonly, in our general practice, we do see many cases. We are not sure when we can treat or when we can refer. So what happens is if there's any delay in treatment of any entropion or ectropion, it can lead to secondary changes in the cornea. And if a case of a child with ptosis, and if we neglect it and not treat it properly, it can lead to amblyopia. And even in cases of lid tear and especially canalicular tear, so if there is failure to, if we fail to repair it at the proper time, it can lead to lifelong epiphora. And so correct approach with timely intervention can avoid many preventable complications. So I'll just talk about the common problems we see in our OPD on day-to-day basis. So we know chalazion is the most frequent lid bump mass which we see. So I'm sure everyone knows the treatment is topical antibiotic, warm compress. But in my practice, what I've seen is compared to giving a wet warm compress, if you give a dry warm compress, it's more effective and the resolution is more quicker as well. So I usually advise my patients for like a hot water bag or like a dry heat compress rather than a wet. And intralesional triamcinolone is still very effective in treating a chalazion, especially if it's in the margin or if it's near the punctum. So I think that also everyone should be a little bit more aware, because directly we all go in for an INC. And another thing is, while doing an INC, we all know the incision and the curettage, but after curating, it is always advisable to remove the lid, the cyst wall surrounding the chalazion, so that it prevents recurrence. And you should also know when to do a HPE in case of a chalazion, especially if you see mild induration, any ulceration, any vessels, if it's long standing, if it's recurrent, and especially in elderly patients, to avoid so that we can diagnose if it's a case of meibomian gland carcinoma. So another thing is ptosis. So what is the role of a general ophthalmologist is to identify the cause, mainly whether it is any traumatic or aponeurotic or neurogenic. You should also know the amount of ptosis, that is the MRP1. So you should know how to measure that. That is from the center corneal reflex to the upper lid margin. Levator function, the Bell's phenomena is very important. And if there's any risk of amblyopia, so that especially in children, more than visual deprivation, anisometric amblyopia is very common in ptosis. So cycloplegic refraction is very, very important. And you should also identify if there is any neurogenic cause, ocular myasthenia or Marcus-Gunn jaw winking as well. So a few points about this is traumatic ptosis. If you encounter, it's better to defer surgical intervention for at least 3 to 6 months, because there are high chances of it to resolve by itself. And in my congenital ptosis, if there is no signs of amblyopia or no abnormal head postures present, observation is very much sufficient, and every 6-month review is enough. But if it coexists with strabismus, usually a strabismus surgery should be done first and then the ptosis correction. So usually in cases of children, it is best to operate between 4 to 5 years of age. Before that, if there's no amblyopia, always treat it conservatively. So another thing is the crutch glasses. If it is inoperable, especially like patients with CPEO, congenital fibrosis of extraocular muscles, and very poor Bell's phenomena with lag of ophthalmos, it's always better to treat it conservatively with crutch glasses. So another common what we see in our general OPD is the CNLDO. So children who come with complaints of watering. We know the treatment is Krigler's massage, especially till the year of 1 year. So 1 year to 4 years, we go ahead and do probing. And after 4 years, only DCR is done. So still many people don't know the exact technique of this Krigler's massage. And we still see patients coming and doing it very in a wrong method. So the thing is, you should just give mild pressure in the medial canthus and push it down your lateral part of your nose. That's it. There should not be any circular massage or not doing it in the part of your lower lid or anything. So you should also be able to identify if there is a lacrimal fistula, because this is not going to work with probing or Krigler's massage, and it's better to refer to an oculoplastic surgeon, because the treatment is fistulectomy. And you should also be able to identify when there is an lacrimal abscess, because the treatment is IND rather than just pushing the patients with IV antibiotics or oral antibiotics. Another common is the orbital cellulitis, which we see. So I'm sure everyone knows the difference between preseptal and when you call it an orbital. So ideally, the management will be to do all the routine blood investigations, blood culture, and we usually start on the 3rd generation cephalosporin along with metronidazole. And it's always good to start such orbital cellulitis patients with IV steroids, especially Decadron 8 mg IV BD can be given if there is no signs of any fungal etiology, because inflammation reduces very nicely. So when do you refer to an oculoplastic surgeon is even after giving 2 days of conservative treatment, there's no improvement in the orbital cellulitis. There is signs of progressive compressive optic neuropathy, and there is also chances of any orbital abscess or intracranial involvement. It's always better to refer do an imaging, because such patients will not resolve with IV antibiotics and they might need orbital drainage. So another is the lid tear. So lid tear around the periocular region, we can do a simple suturing with 6-0 Vicryl. Even the lid margin suturing also can be done if it's done properly in all the 3 layers involving the tarsus, the anterior lamella and the posterior lamella is well approximated and it's done. Anyone can do it. It's a simple procedure. One thing you should keep in mind is if you're doing it in the upper lid, it's always better to avert the knot and suture it so that it doesn't abrade on the cornea. But if it involves a canalicular tear, you should repair it within 72 hours. So its timely referral is very important, because then it starts getting fibrosed and chances of putting an intubation will become difficult, and even post-operatively chances of extrusion of the tube is also very, very common. So why it's important for canaliculus to be repaired is the anatomy is restored, the normal eyelid pump and drainage physiology is returned, and there is no chance of or minimal chance of patient developing an epiphora. So as you know, this is done by a monocanalicular stent. So thank you.
Thank you very much, Dr. Sindhuja. That was a wonderful presentation. There was an article by Dr. Milind Naik, Myths in Oculoplasty, Dirty Dozen. So this actually was very useful. Maybe, YouTube also, you can share the YouTube link, and many general ophthalmologists will benefit from that. Over to Dr. Pradeepa for
thank you, Sharmila ma'am, and thank you, Dr. Sindhuja. I was wondering how you'll be covering it in 2 minutes. I think you did a very wonderful job.
I just took all the important points only.
I just wanted to share my few cents among the slides which you have put. Can you just share the first slide alone?
Yeah,
so the first talk was the lid mass. So when it comes to a child, the picture what you have put, so it was not a chalazion. Actually, in children with a lid mass, particularly in the lateral, dermoids can mimic them. So if at all we see a picture like that, it is better we do an imaging to confirm whether it's a dumbbell dermoid. Just the first slide of a child. So that didn't look like a chalazion to me. So in case you see a child like that, the third slide, please. Third slide, the child with lid mass. Yeah. So it looked more like a dermoid rather than a chalazion. So when we have suspicion, it's better to image, particularly in children, because we should not be missing a dumbbell dermoid. And very rightly, she said for adults with a chalazion-like picture with a swelling like that, if we have suspicion. So when do we suspect that there is a malignancy? The lid margin architecture is lost. There is loss of flashes. There is prominent vasculature. These 3 signs are very pathognomonic for a malignancy. When you see a swelling in the lid in an elderly person, definitely we should do a biopsy or plan with the margin clearance. That she rightly said. The second thing in DCR, when you told, yes, rightly in congenital nasolacrimal duct obstruction, we have to do massage, Krigler's massage up to 1 year, and after that we have to do probing. And the cutoff age for DCR is not 4. There is no cutoff age for DCR. When a mother or a parent tells that my child has watering since birth, but a probing is not done yet, the first procedure, even if it is at 7 years or 8 years, if the child comes first for the watering complaint, which is there from birth, it has to be probing. This is what my teacher has taught me. If I'm wrong, anybody can correct it, but that is what I keep following it up here, because that is a patient with congenital nasolacrimal duct obstruction. So that patient has to undergo a probing before a DCR. That is what I have learned from Dr. Bipasha. So I thought I would share that in this forum. And next, coming to orbital cellulitis. Yes, orbital cellulitis, when we suspect, definitely we have to image. I don't give steroids, as you say. Maybe it might work if there is no fungal etiology, but we do not know whether the patient has a fungal infection. So how are we ethically right in giving a steroid without knowing that? I just had a small suspicion. So we only give IV steroids. But one thing which I want to share is if there is an orbital cellulitis, and when we are in a patient with orbital cellulitis, it is very important to look for the other eye, and particularly the movements of the other eye, and particularly the abduction, because a sixth nerve palsy of the other eye will give a clue that the patient is going in for some cavernous sinus involvement. So that is very important. As a general ophthalmologist, we should keep following that up. And canalicular tear, very nicely she said, yes, it has to be repaired within 72 hours. because the success rate is more. But even if they come late, we can attempt. Many a times this canalicular tear is missed in an emergency department because that particular the wound will be partially sealed. So we should take a moment to see that area with a bud and look in slit lamp so that we don't miss a canalicular tear. And last one thing for general ophthalmologist, my pet topic, thyroid eye disease. We see a lot of patients with thyroid disorder. Many patients have inactive thyroid eye disease. So we should look for signs of lid retraction or lid lag in patients of systemic thyroid disorder. And these patients have occult dry eye disease. So it is better and most of them have a deep-seated pain or a irritation or a early morning discomfort in the eye, which is probably because of thyroid. So we should probably look into that. These are few of my points which I wanted to share.
Thank you, Dr. Pratibha, for those clinical pulse.
Sharmila, I just want to.
Yes, ma'am. Yes, ma'am. Please tell me.
Because of short of time, you may shut me up. That's it. I'm taking your
question. No.
Okay. So this dry heat, Dr. Sindhuja was telling, no, what I do, I ask them to place a finger on cooker or something which is very hot and then keep it right on the chalazion. It really works because it worked for me. So I know it really works very well. Okay. And another thing is for one 5-year-old girl, she was advised to have incision for chalazion and I advise this heat application. And now she is 25 years old and she still comes all the way from Porur. The whole family comes to me for anything in the eye. So that the dry heat really works, even without any ointment, I'm telling you. Okay,
and what is the antibiotic of choice for lacrimal abscess? May you know?
We usually prefer augmentin, ma'am. They work. Augmentin works very well for all this ocular and related pathologies.
Soft tissue.
Yes, ma'am.
Yeah.
And another thing
Excellent.
is massage should be taught. Just like what Sindhuja told, everybody does it in a very wrong way. I ask them to do it in front of me and then only leave them.
Correct.
Shall we move to the next case, ma'am?
Yeah, we'll move on to the next presenter.
Dr. Ovia, are you ready?
Yes, ma'am.
Yes, Ovia, it's visible. You can go ahead. Zovia's voice more? Can't hear.
Ma'am, can you see me? Can you hear me?
No, I can't hear you. No, only,
Yes.
Go ahead. Yes, yeah.
Yes.
Good evening, everyone. I'm Dr. Ovia Krishna Gopal. I'm doing my first year post-graduation in Shankar Nethralaya. My moderator for today's presentation is Dr. Matangi Shri. She's a cornea fellow from Shankar Nethralaya. So I'll be presenting a case on infectious keratitis. A 38-year-old female from Uttar Pradesh came to us for the first time with complaints of redness and blurring of vision associated with watering and discharge for the past 1.5 months in the left eye. On local consultation, corneal scraping was done and the smear grew septate fungal filaments. She was then put on antifungals and antibiotic cocktail with homatropin and anti-glaucoma medications. She has no other significant ocular or systemic comorbidities. Her general examination and systemic examination were well within the normal limits. Torchlight examination showed normal head posture, normal facial symmetry, and full and free extraocular movements in all cases. Ocular examination of the right eye showed visual acuity by 6 with normal slit lamp examination findings. Left eye visual acuity was PL present with inaccurate PR. The lids were edematous and circumcorneal congestion was present. The cornea had a ring infiltrate of size 9x8 mm with a dried looking base and a feathery margin. Central epithelial defect was noted in the cornea, which was also with also pseudocornea present with it. AC was flat and finger tension was soft. Now, the fundus view of the right eye was normal, but the left eye wasn't visible because of the corneal ulcer. So, based on these findings, our provisional diagnosis is the left eye perforated corneal ulcer with the pseudocornea. A gentle ultrasound V scan was done in the left eye, which showed 360-degree choroidal detachment. Left eye corneal scraping was deferred in view of the pseudocornea, and syringing in both eyes were patent. Now, in view of the large perforated ulcer with the huge choroidals, the patient was directly taken for the left eye therapeutic penetrating keratoplasty. Now, post-operatively, the AC exudate was sent for PCR and was found to be positive for the U bacterium genome. So now the patient was started on dual antibiotic therapy and the patient responded very well to the medical treatment. Now over to Dr. Matangi to explain the surgical steps and the take-home message.
Good evening, one and all. I'm Dr. Matangi from Shankara Nethralaya. So I'll be discussing the surgical steps of therapeutic penetrating keratoplasty, which was done for this patient. So while we were waiting for the TPK, patient underwent cyanoacrylate glue with BCL. So flaring fixation was done for globe stabilization and scleral support. Then the glue was removed. Once the glue is removed, we can see that there is a large perforation. The graft size is measured using calipers. And the host cornea is defined using 8.5 mm corneal define. The corneal edge, which is left, is dissected using corneoscleral scissors. And then viscoelastic substance is used to form the anterior chamber. The exudates which were present over the iris was removed and peeled off. After this, we found that the crystalline lens was absent, probably extruded. And then minimal anterior vitrectomy was also performed. The donor cornea was defined with a 9.5 mm corneal define and sutured to the host corneal rim. So here we can see the cardinal sutures are made at 12, 6, 3 and 9 o'clock positions using 10-0 nylon sutures. Here we use 16 interrupted 10-0 nylon sutures to suture the donor rim, and viscoelastic wash was done before taking the last suture. After the suturing is completed, AC wash was done and the anterior chamber is formed and checked for wound leak at the graft host junction. So the take-home message here will be importance of microbiological investigations in infectious keratitis, as initially the patient was found to have fungal filaments in the smear, but the AC exudate shows eubacterial genome in the PCR, and close follow-up of the patients to rule out secondary infections and to titrate the medications according to the clinical response. Thank you.
Thank you very much. Vasudha ma'am, can we have your comments?
I just have one doubt. The ulcer was perforated and the eye was soft, no? Why did you give brimonidine? For all cases you will give.
Ma'am, it was given outside. Ma'am. When the
Dr.
patient presented to us, patient was using the anti-glaucoma medications. We stopped it later.
Oh. So I was wondering when I just saw the brimonidine part and then I was wondering.
Yes.
Do you do PCR for all the cases?
No, ma'am. When if it is suspicious, because the patient was already on antifungal and a cocktail of medication, to rule out if it is a secondary infection, we have sent for PCR also.
So post-operatively, what drops did you give him?
Post-operatively, we continued the vancomycin. The patient was using vancomycin and ceftazidime in a lower dosage, like 4 to 6 times. We started it on an hourly basis, vancomycin and ceftazidime, and patient improved with the medical management, like with the medicines post-operative.
Did you start on steroids also for these patients?
Yes, ma'am.
So it was definitely not fungal there.
Ma'am, we suspected that initially it could be a fungal infection, but it was initially the patient was only on one antifungal and two antibiotic. So it could be a toxicity of the multiple medications which could lead to corneal melt. When we sent the sample for the culture, there was no bacteria or fungus in the culture, ma'am. So we started on the steroids post-operative.
So I just thought I will add something. Yeah, if I
Yes,
may.
ma'am.
Can I
Yes,
just
Yes,
add?
ma'am. Sure, ma'am. Sure.
So the patient came with a diagnosis of fungal, but he was on two antibiotics, dual antibiotics, and just a single antifungal. The doses were not adequate, and he has come with a large area of melt and perforation. So we were not sure of the diagnosis of fungus. We have very limited material for histopathology. That is why the reason we also added PCR. But from our report, we only got PCR positive for bacteria, a smear culture all negative for all agents. So we are left with the choice of treating based on the PCR mainly. So we started safely with the antibiotic because the patient's initial antibacterial management was inadequate. So that gave us a hope that it could be antibacterial. We didn't want to start the patient on everything. So we just started on the same antibiotic, but a proper dose, and then it improved. As it improved, once the epithelialization happened, then we put the patient on steroids, and he is so far. So probably it is bacterial, or his original fungal infection could have been healed, and this is a secondary infection. But what we dealt was a bacterial only based on the clinical experience.
The only
Thank
reason
you.
why we should suspect fungal is because it's a chronic infection. Patient has been having this infection for more than 1.5 months, and it's very rare to see a bacterial infection being so much prolonged, unless,
Yeah,
like you
but
said,
our microbiology should have produced. So that is why we didn't start.
Good point. Ma'am, Vasanta ma'am, any comments, Shabila?
That's a nicely done surgery. I just had one doubt and that was clear.
I think Dr. Bala Saraswati is ready with the presentation. Can we have Dr. Bala Saraswati?
Dr. Kalpana?
Ma'am, can we have the next? I think she's on a call.
Yeah, we can move on to Dr. Bala. She's ready.
Madam is connecting, I think.
Yes, ma'am. Manjula will start sharing the screen from Numerotech.
Yeah, ma'am. See.
Is this fine, doctor?
Yeah, you can go
Yes.
ahead.
Okay,
Audio
shall I
is also
start?
there.
Yeah, please.
Start?
Yeah. It's a 54-year male with a hypermetropic cataract, and there was a dense ALC calcification over the capsule. So I just started with the Rexus, but couldn't do it because of the very thick plaque in the center. So in the periphery, just made a nick, and with the forceps, I tried to extend it, and the fluid escaped. So a little bit extruded the fluid from the bag, and again tried with the forceps. But since it was a small nick, I couldn't make a clear-cut flap. So I cut with the vanas in the center. Got stuck.
Manjula, ma'am? Yeah.
And after that, the flap was made. And the main thing was it was fully in the center, and only in the periphery can make a rexus nicely. And towards the nasal side, it got extended a little bit, since that area was only free of the calcification. So with the Little's maneuver, I tried to pull it inside. Got stuck. Okay.
Well, you can continue with your presentation. Maybe the video.
Okay, the video is on hold. So again with the Little's maneuver, I tried to pull it inside, and I made a flap over it and completed the rexus by pulling it inside. And then, as usual, the phaco with the chopper, I made into two vertical chops, stop and chop, and it was a little 14 nucleus also, and divided it into 6 quadrants, and then removed all the fragments. The main thing is you should bury a little deep and until the posterior plate is separated. Otherwise, all the posterior plate will not separate, and only the anterior will get separated, and it is little hard to take out the nucleus. Then once it's all separated fully, then take it into the AC and emulsify it. The main difficulty in the hypermature calcific cataract is the rexus. We usually do it with the vanas and then cut it, and usually it will be extended or it will be like a capsulotomy. But if we avoid the central calcified area and move it to little periphery where the calcification is little less, we can complete the rexus nicely. And all the Little's maneuver and the circumlinear tangential force, if you give it to the capsular flap and redirect it properly, then we can do a nice rexus, and then your phaco will be very good. The rest of the steps will be neat.
Very nice surgery, doctor. Maybe when I get cataract, I will come to you.
Okay, madam. Thank you, madam.
Yeah, hard lens like that, I do SICSR because I have dropped one very hard cataract.
Yeah.
Sujata only removed it from the vitreous. So I will
No,
never.
actually, one more thing, like whenever the hard cataract is there, usually I never do hydro. And like a PPC, I take a V-like pattern and take one nucleus so that the bag get little decompresses, and then only I used to rotate the nucleus. Otherwise, that nucleus only is very heavy and it will weaken the bag. Or sometimes with the hydro only, the capsular blowout will happen, and on rotating it will drop out. So whenever I do hard cataracts, I never do hydro. Little or very minimal hydro, and like a V pattern, I take 1 pi of the nucleus first with a chopper, and then afterwards there's some space in the bag. So like especially for pseudo exfoliation or very hard brown cataract, it is really very good. It helps so that the bag becomes little spacious and you can move around and take out your nucleus.
Excellent surgery,
Thank
doctor.
you.
Very
Thank you, madam.
at the points, in what I do for hard cataracts. Today, I had a very black cataract, and I do a larger rexus, and I tell everybody it's going to take time. Be patient. Like you said, you have to go by after each piece
Right.
slowly and steadily without giving in, and also use adequate viscoelastic to protect the cornea, and try to do a in the back phaco than doing a phaco in the anterior chamber. So if you're patient, you can definitely conquer hard cataracts, and your surgery was excellent.
Thank you, madam.
Dr. Hridaya there? Dr. Hridaya?
Yes, ma'am, I'm here. I think it was wonderful surgery by Dr. Bala. I just want to add two thoughts on this. As she said, in sclerotic calcified capsules, we initiate the rexus away from the area of the calcification, then continue with the rexus forceps. And once you encounter the area of calcification, cut with a 1-hour scissor from the main port. But that's more easily said than done. So sometimes it's not accessible because it's away from the main port incision. So in such cases, it's ideal to place some additional incisions away from the main port so that you can try to cut with the vanus from a different direction. And preferably, it's always better to use a micro scissor and a micro forceps because micro scissor and micro forceps because that makes the cutting a lot more easy. And also in dense calcifications, the surgeon can also opt for a vitrectomy cutter, which comes in quite handy in making the rexus in such cases. Just one more thing I wanted to add is although the anterior capsule is like calcified and thick in these patients, some of them will have a piece, the posterior capsule will be just the opposite of it. It'll be very friable, thin, and billowing when you're trying to do emulsification. So in such cases, it's better to push down the posterior capsule using using a viscoelastic, reduce your phaco-parameters so that the turbulence is reduced. And also, I prefer to use the IOL scaffold technique before removing the last few fragments so that the PC is pushed down, you don't have an iatrogenic PCR. So these are the two things I wanted to add, and I'd like to thank TNOA for this opportunity for us. Thank you.
Thank you so much, Dr. Hridaya. Can we move on to the next presentation? Dr. The unilateral glaucoma, Dr. Veni Priya.
Yes, ma'am.
Yeah, you can start it.
You will see my slides.
Yeah.
Good evening, everyone, and thank you for this opportunity, ma'am. So today we will today I will going to present a case on unilateral glaucoma in an adolescent patient, a diagnostic dilemma. And we all know that pediatric glaucoma is defined not only on the intraocular pressure increase, it depends on the corneal findings and progressive myopia and axial elongation along with
A little bit
optic nerve
louder,
lesion.
please.
Yes, ma'am. Can you hear me, ma'am?
Yes, ma'am.
Yes, ma'am. So the pediatric glaucoma not only depends on the intraocular pressure, optic nerve changes, and visual field changes as like adult glaucoma. The corneal findings and the progressive myopia and axial length and elongation must also be considered into the diagnosis. So here we see a case of 15-year-old male patient came with the complaints of right eye defective vision for the past 4 years, which is a progressive painless loss of vision. He comes from West Bengal from Calcutta. And he has a history of allergic conjunctivitis for which he is on irregular treatment and was using topical steroids on and off over-the-counter medications. At present, he was on tacrolimus eye ointment and Vinalope double-strength eye drops, both eyes. There was no history of trauma or no history of consanguinity marriage among the parents and no family history of glaucoma or unexplained visual loss. So on examination, the vision in the right eye was hand movements with the perception of light positive, and IOP was 44 mm Hg by GAT. And there were a lot of papillae seen in the limbus and also on the lid, in the palpebral conjunctiva. Cornea was clear, there was no half striae. AZ is normal depth and pupil was showing RAPD, then there was lens was clear. The left eye vision was 6.6 and IOP was 12 mm Hg and papillae was seen and cornea is clear, there was no half striae and with the normal anterior chamber depth and pupil was reacting to light, normal in size and lens is clear. And on the right eye was showing a limbal stretching and the corneal diameter was 12 and in the vertical and horizontally 13 in the right eye and with the axial length of 26.62 and the refraction showing myopic refraction. In the left eye, it was 11 and 12 in the corneal diameter and with the axial length of 22 and the refraction was showing plus 2.25 and vertical and horizontally it was neutralized with plus 1.75. And both eye gonio was showing open angles with moderately pigmented trabecular meshwork and prominent iris processes. And on fundus examination, right eye was showing advanced cupping with 0.9 with superior concentric cupping and a superior inferior thinning in NRR thinning. And OCT is also showing RNFL thinning. Left eye was showing 0.5 to 0.6 CDR. ISNT rule was maintained. And this is the left eye field analysis showing normal visual fields and reliable fields. So coming to the diagnosis, it is a unilateral glaucoma with the right eye with both allergic conjunctivitis. Maybe a primary congenital glaucoma because of the limbal stretching, increased corneal diameter and axial length, myopia. And it may be a joinal open angle glaucoma considering the axial length, myopia and prominent iris processes. Steroid induced may be an added component because usually it is not associated with the ophthalmic features. So we started him on etinoprost in the right eye and timolol in the left right eye and with the diamox and left eye was observed and to continue anti-allergic medications. Patient lost follow-up, unfortunately. So discussing the unilateral PCG was diagnosed as the fellow eye remaining normal beyond 2 years of age, showing no corneal enlargement or axial length increase or optic nerve coupling or typical corneal signs. And they have also told fellow eye should be called should not be called as a normal one. It is a formiferous state or a currently disease-free disease, and they have to be followed up for lifelong. And juvenile open angle glaucoma can be unilateral because of the variable developmental anomaly of the trabecular measure between the two eyes. Steroid induced can also present as a unilateral if there is a improper installation of the in the left eye due to the reflex eyelid closure following right eye drop application. So this patient had a VKC asymmetric, like the right eye showing more papillae. Maybe the higher dosage was applied in the right eye, and it may be due to the genetic and anatomical differences also. So coming to the treatment part, we have to stop steroids and we have to go for steroid sparing agents with systemic immunomodulators. And for the right eye, maximum medical therapy has to be given, but ocular surface also has to be kept in mind because the patient is already having allergic conjunctivitis with, it may go for limbal stem cell deficiency. Trabeculectomy with MMC, the success rate in the young patient, and with this ocular surface, we have to think. And the cyclophotocoagulation, patient is young, one-eyed, and needs multiple sessions. And selective laser trabeculoplasty and a mix. It is efficient in mild to moderate cases, but the efficacy in these cases is questionable. But it can be used as to reduce the number of medications, to stabilize the ocular surface, or to postpone the surgical procedure as an interim management. To conclude, unilateral pediatric glaucoma is rare and diagnostically challenging. Secondary cases has to be ruled out. Careful history, examinations, and investigation has to be done. And always the fellow eye has to be kept under a very high index of suspicion, and a low threshold for the diagnosis of glaucoma for the fellow eye should be done. Thank you.
Thank you, ma'am. Can we have Manjula, ma'am?
Ma'am, this is Dr. Vijaypriya, moderator for this session.
Oh,
Can I
sorry.
just add
So,
a few
yes, sure.
words?
Sorry.
Yeah, thank you, ma'am. Good evening, respected seniors and friends. Ma'am, this case was presented because it was a young patient who had unilateral glaucoma with history of allergic conjunctivitis, and patient was on and off steroids. PCG was considered because of the ocular enlargement, which was in the form of increased corneal diameters, increased axial length, and progressive myopia. But the only thing against this was it was unilateral, because most of the cases of primary congenital glaucoma, 60 to 90% of the cases are usually bilateral. JOAG, juvenile open angle glaucoma, was another consideration because of the increased axial length, the myopic component, and prominent iris processes. But what was against it was the increased corneal diameter and limbal stretching seen in the right eye. The steroid component must have been an additional component which is added on to the glaucomatous damage. So unfortunately, after starting the therapy, the patient was lost to follow up. So we don't have follow-up of this patient here.
Thank you, ma'am. And with this kind of an ocular surface, would you prefer prostaglandin as a first step, no? The patient already has an allergic conjunctivitis.
It can exacerbate the allergic conjunctivitis, but the intraocular pressure was 44 millimeters. So we had started on latanoprost, as well as the patient was also started on primordial therapy also, madam. And acetazolamide therapy was also started. And the patient was asked to review back after some time for the follow-up and surgical component if required. Subhashini, ma'am.
Just wanted to, as rightly discussed, Dr. Vijaypriya has clearly said the corneal enlargement was the main point against the diagnosis of juvenile open angle glaucoma, because if the cornea is enlarged, that it means that the inciting factor had started much earlier, before 3 years of age. So we need to rule out the acquired causes. Here, trauma was not there. Uveitis, if, we need to rule out. And then one other important condition that it has a separate place, separate entity in that CGRN classification, the Childhood Glaucoma Research Network classification, that is glaucoma following cataract surgery. So sometimes children with unilateral, infants with unilateral cataract surgery is done, and then they develop glaucoma following the cataract surgery. So this is an important thing to rule out. But here the lens was visible. For this condition, actually the steroid is just one aggravating factor. We can only think in terms of the rare entity like primary unilateral primary congenital glaucoma.
Thank you. Thank you, ma'am. Vasanta ma'am, are you there?
Okay, there are too many cases now, we'll continue.
Okay. Can we move to the next presentation? Dr. Padmapriya?
Yes, ma'am.
Yeah.
Am I audible?
Yeah.
Okay, good evening, dear all. Myself, Dr. Padma Priya. I'm here to present a video demonstration of how to approach a patient with committed exotropia along with vertical strabismus in the same eye. My mentor is Dr. Manjula Jayakumar. So we had a 23-year-old patient who presented with both eye axial myopia, anisometropic with right eye power minus 6.5 and left eye minus 33. She had a pathological myopia in her left eye due to peripapillary staphyloma and with a poor vision of 1/60. She had a 25 PD exotropia with 20 PD hypotropia complex. And also she had a pseudotosis element along with a mild elevation deficit of 1 minus. Right eye extraocular movements were full and free. Axial length in right eye was 23.6 and left eye was 30. So we planned under LA for a left eye 3 muscle surgery as it was an amblyopic eye. So we planned for left eye LR recession and MR plication to deal with the exotropia component and IR recession with fade-in for the hypertropia. So this is the surgical video and it shows IR recession with fade-in. So this video is from the surgeon's view where inferior limbal peritomy is done. The inferior rectus muscle is isolated and secured with a 6-0 vicryl suture using a 3-point fixation technique where the central knot is a square knot followed by locking bites on either side. So for the locking bites, the first will be a partial locking bite followed by a full thickness second locking bite. So it is being done on either side. For fade-in, so a non-absorbable 5-0 ethibond suture is taken and a central fixation, 3-point fixation technique is being done. And this is done at 9 mm from the insertion. So fade-in literally means it is a suture in German. So around 15 mm from the insertion, a partial scleral pass is made on either side of the muscle with the ethibond. The muscle is disinserted and recessed at 6 mm from the insertion. The non-absorbable suture is brought back inward along the sides of the muscle at the 3-point fixation point and a central knot is tied and thus the muscle is held posteriorly. So the fade-in is literally to weaken the muscle in its side of action. And the conjunctival closure is done. So what follows is the 1 week post-op and then 1 month post-op pictures. Thank you. Over to Dr. Manjula for her valuable inputs.
Of high myopia, which is associated with heavy eye syndrome, which is an esotropic hypotropic complex. This happens because the posterior staphyloma will prolapse outside the muscle cone between the superior rectus and lateral rectus, diverging these muscles apart. The superior rectus will get shifted nasally and the lateral rectus will get displaced inferiorly. And as this happens, the globe progressively keeps going downwards and inwards. And then you get a strabismus fixus, myopic strabismus fixus, where there is a severe restrictive myopathy. The globe is fixed inward and downward. Now, this is the other type of strabismus that can happen with high myopia. This is called as the hypotropic exotropia. The eye is down and out. Now, this is like a sensory strabismus. And because of the poor vision, the eye goes into that point of rest or position of rest, which is the out and down position. And initially, the extraocular motility can be good, as in this case, but later on, as the patient develops inferior rectus contraction, you find that the elevation deficit also increases. Now, in myopic strabismus fixes, we always do a radiologic diagnosis or a neuroimaging because we want to see the shift in the muscle pulley. But in this case, hypotropic exotropic complex, radiological diagnosis is not necessary because more often you will not see any displacement of the muscles either on the radio diagnosis or even intraoperatively. So there are various options. How will you treat this? Now, since we have done 3 muscles, we have done one muscle, a vessel sparing, that is plication on the medial rectus. This is a very large hypertropia case. There is a 25 PD hypertropia. The maximum that you can recess is 5.5 mm, maximum 6 without causing any lid aperture changes, lid position changes. So that is why we have a very large hypertropia. It's a 25 PD hypertropia and a 25 PD exotropia. So we have combined recession with faded to give a good correction for that. That's why the globe has lifted up. And it will remain like that. Now she's on follow for 3 years. And the globe has remained lifted up. And for the XT, we usually, since it's a sensory XT, we correct a little more. We leave it a little esotropic because an outward drift is going to happen with time. And even on the last visit, which she came about 6 months ago, actually Padma has seen her in Vellore, the eye is properly positioned and cosmetically well aligned. We have not given her any kind of contact lens or any other visual rehabilitation in her affected eye because the vision is very poor. It's only 1/60, densely amblyopic, and the patient does not improve. So in these cases, the way we handle squint is different from patients with good vision. We don't want recurrences. Recurrences is the defeating purpose of the surgery. So we will handle the muscles in such a way that if you don't correct the hypertropia properly, you're going to have a recurrence of hypertropia. That is why we have combined inferior rectus recession with faded. We have also done LR recession with MR plication adequately to correct that small exotropia. So there is a different way of approach to sensory XTs with hypertropia like this, which we can see in very high myopes. We presented this case because we are all aware of the myopic strabismus fixes, but equally this is an important entity which we see more than often. High myopes can also have exotropia, hypertropia complex. And this actually, not many case reports are there. One is by Ramesh Kekunia et al., where actually Dr. Monga has done a series of cases. They have different approaches. Some people do even nasal loop myopexy. But nasal loop myopexy is uniting the superior rectus and medial rectus. In myopic strabismus fixes, we do the usual lateral loop myopexy between the superior rectus and lateral rectus. But there you have a good working space. Whereas nasal loop myopexy is not all that easy to do. So this is a better approach. And another thing is people do R&R with just updrift of the muscle, upshift. They shift the muscles vertically upward. Even that doesn't correct so well if you have a 25 prism diopter of hypertropia. And we wanted to go ahead and do this
Thank you very much,
in a single setting. So that is why we have combined all 3 muscles in a single setting. Any doubts?
Thank you very much, ma'am. Wonderful outcome and wonderful explanation.
Okay, thank you. Thank you, Padma. Very good presentation.
Thank you. Wonderful explanation, ma'am. Thank you.
Thank you. Thank you so much.
We move to Lakshmi Priya for a series of cases of pediatric uveitis. Lakshmi Priya, you can start your presentation. Dr. Aishwarya can give her expert comments after the presentation. So we'll have the presentation and then the expert comments followed by 2.
Yes, ma'am. Good evening. Yes.
How many Priyas are there?
Devis, lot of prayers. Navrat.
While she's trying, what is the pseudotosis due to, Dr. Manjula?
What, ma'am?
Pseudotosis. That lady had
Pseudotosis got corrected, ma'am, because we shifted the globe adequately up. So the pseudotosis got corrected. Once hypotropia goes, pseudotosis will go. Because the globe was down, we had a pseudotosis.
Okay.
We didn't do any ptosis surgery for her. Cosmetically, she was acceptable.
Okay.
Yes, Lakshmi Priya, you can start the presentation. Your voice is not audible. Are you presenting? Lakshmi Priya, you're muted.
You have to
Yeah.
unmute. You have to
Lakshmi Priya, please unmute and then start presenting.
start
Yes,
your
ma'am.
presentation, ma'am.
A 6-year-old female child brought with a complaints of intermittent outward deviation of the left eye.
You have to share your
Ma'am,
screen, Dr. Lakshmi Priya. It's
yes,
not,
ma'am,
you're not
sorry.
able to see it.
No, I was able to see your screen previously.
Yeah.
You were muted then. Yeah.
Yeah.
Both of them are from Tanjore Medical College, ma'am.
Oh.
Yes, ma'am. Shall I start now, ma'am?
Yes, yes, please.
A 6-year-old female child brought with the complaints of intermittent outward deviation of the left eye, first noticed by her father. History of redness present in the left eye for past 1 week. History of contact with pet animal was present. No other significant ocular history was present. No history consistent with TB, arthritis, or viral fever. The birth and developmental history were normal. No significant family history was present. General examination were normal. On ocular examination, right eye was normal with 6/6 vision. Left eye has CF with pigmentary dusting over the lens, and the rest of the anterior segment findings were normal. The right eye fundus were normal. The left eye fundus was hazy due to grade 3 vitritis. A solitary whitish elevated posterior pool granuloma of 1 disc diameter is seen involving the macular area with vitreoretinal tractional band extending towards the optic disc. B scan showed ma'am.
Yeah,
B
continue.
scan showed, yes, ma'am. B scan showed left eye vitritis. B scan B scan showed
yeah, we saw the B scan. There are no more pictures, just continue.
Yes, ma'am.
Aishwarya, you want to join before she gets it? Aishwarya?
Ma'am, good evening, ma'am. Good evening, ma'am. Ma'am, actually, this case, we had, at this time, we had 2 cases
Can we
of
have your video?
pediatric. Yeah, ma'am.
Yeah.
I think she has come back, ma'am.
Yeah.
Once she
Yes, ma'am.
finishes,
Yes, ma'am. Sorry,
It's
ma'am.
okay. You can. No, you finish your comments,
Yes.
Aishwarya.
Ma'am, shall I?
B scan.
Yeah, please go ahead.
Ma'am, actually, we are presenting these 2 cases of pediatric uveitis to insist that pediatric uveitis is being more commoner nowadays with different etiologies. Actually, the first case had a classical picture of a posterior pole granuloma with a vitreous traction band. So the picture itself says that straight away, since she had a history of contact with pets also, we had a strong suspicion of toxocara. And we just investigated for all other things, tuberculosis, syphilis, toxoplasma, everything, and also asked for a absolute eosinophil count, which obviously was increased in this case. Based on we were asking for specialist opinion to rule out any systemic manifestations of the disease, but nothing came to be positive. And it was a rare case of unilateral ocular toxocariasis. So based on this clinical picture, we started the patient on oral steroids and tablet albendazole. After treatment, there was a slight improvement. There was no significant improvement in vision as the granuloma was sitting right over the macula. But the inflammation had come down from the grade 3 vitritis. The vitritis slightly reduced to grade 2. And then since she was responding, we were planning for vitrectomy for this patient. And we are waiting for general anesthesia assessment for this patient, ma'am.
Overshadow of the CNS examination.
Sorry, ma'am.
No, I think. Manjula ma'am, can you yeah.
Yes. Next case, ma'am, can she present or shall I, ma'am?
She can present. She can present the case too.
Yes.
11-year-old male child came with a presenting complaints of defective vision in the right eye for 1
Just
week.
tell the positive findings, no? Because we're running out.
Yes, ma'am. There was a history of recurrent episodes of redness in the right eye for past 6 months. No significant past history, and there is no significant birth or developmental history. On general examination, right submandibular lymph node was palpable matted lymph node was seen. On ocular examination, the vision in right eye is 624 and left eye was 66 with both eye anterior segment within the normal limits. The right eye fundus was hazy due to grade 2 vitritis. Disc and vessel were poorly visualized. Well-defined yellow-white choroidal granuloma was seen in the infratemporal periphery with surrounding vitreous condensation. Multiple whitish retinal infiltrates seen in the infratemporal periphery with perivascular sheathing was noted in the infranasal quadrant. The left eye fundus was normal. B scan showed PVD with vitritis. Investigation CBC were normal. Only ESR and CRP were elevated, and MAN2 chest X-ray, toxoplasma, torch panel came out to be negative, and CBNAT were negative. FNAC showed reactive hyperplasia, and chest physician and opinion was obtained, and pulmonary and extrapulmonary TB were ruled out. Due to strong clinical suspicion and due to presence of submandibular lymph node, ATT was initiated as per weight. And after 1 week follow-up, vision improved from right eye 624 to 612, and vitritis reduced, and resolution of retinal infiltrates were present. And after 1 week of ATT, we started the patient on systemic corticosteroids, and the vitritis started getting resolved. Ocular TB can present without systemic sign. Diagnosis is often presumptive, especially in endemic areas. Negative test does not rule out TB, especially in extrapulmonary form. Prompt ATT and steroids can preserve vision and prevent complications. Thank you, ma'am.
Thank you, Lakshmi Priya. Vasanta ma'am.
I'm just seeing how many more cases are there. Let us continue, Sharmila.
Okay. Nice presentation, Lakshmi Priya. You should always get your laptop. Since you presented from mobile, probably it's happening.
Sorry.
Can you move to the next speaker?
Speaker.
Dr. Mainaka?
Dr. Menaka.
Dr. Menaka? Dr. Menaka is not available. Dr. Janani? Dr. Janani, can you have a presentation?
Mrinalini has to present, no? Mrinalini?
Yes, ma'am.
I can see Dr. Menaka. Is she trying? Dr. Menaka?
Yes, ma'am. Mrinali, ma'am, you're muted, ma'am.
Yeah, I think she's having difficulty in connecting the presentation.
Dr. Janani can present. We can have
yes,
Dr. Menaka's presentation.
Yes, ma'am.
So, good evening, everyone. So, today my topic is on dealing with hypertonic following trabeculectomy in iridocorneal endothelial syndrome. A 40-year-old lady presented with gradual, painless, progressive diminution of vision.
0.04%. 2 milligram in 10 ml sterile water gives 20 microgram or 0.2
Janani, please wait.
ml or 0.02%. When injecting, a lower concentration of 0.05 or 0.1 milligram per ml can be used. Injection mitomycin C is given after
Manjula ma'am. Manjula ma'am, can you stop the
The video is not playing.
Video is not playing. Manjula, there is a lot of problems with this audio visual today. Everybody is having problems.
So Dr. Menaka and Dr. Janani, both of you have video-based presentations, is it?
Manjula, are you there?
Yes, doctor. Yes, doctor. I'm checking, doctor.
Dr. Menaka and Dr. Janani, both of your presentations are video presentations, is it? Can we have Dr. Shruti
No,
address?
no. Janani's is just a case.
Yeah. Menaka's is a video presentation. Yeah.
Then Dr. Janani can present a case while Dr. Menaka gets it ready.
Janani, you can start presenting.
Yes, ma'am.
Yeah. Screen sharing.
Yes, ma'am.
Why is it taking so long? I think that is delaying the whole process. Manjula?
You're able to screen share?
Yes, ma'am.
Janani?
Yes.
What is happening?
Ma'am, 1 minute, ma'am.
You need help?
Yes, I'll share.
You can probably share your presentation with Manjula ma'am. She can also share it.
Okay.
Numerotech Manjula ma'am.
I don't think she has the number.
No, you can share it in the group. We'll share it.
Put it in the group. Can we go on to the next presentation, Sharmila?
Yes, ma'am. Dr. Shruti, can you present your case on pulse and management of CVI? That again is a video. Dr. Shruti?
Put it on the Manjula's.
Yeah.
Shrutik is good.
Is my slide visible, ma'am?
Yes, Dr. Shruti, please go ahead.
Good evening. I'm Dr. Shruti, Pediatric Fellow from Aravind Hospital, Coimbatore. My moderator is Dr. Amrita ma'am, Medical Officer, Pediatric Department, Aravind Hospital, Coimbatore. So today's topic will be tailored interventions, personalized approaches for children with cortical visual impairment. So cortical visual impairment encompasses a spectrum of visual impairments caused by an underlying brain abnormality that affects the development of visual processing and is characterized by deficits in visual function and functional vision. Unlike ocular conditions, CVI is highly variable and each child presents with behaviors, preferences, and challenges. Individualized therapy plays a vital role in rehabilitation. So tailoring interventions to a child's specific needs, environment, and functional vision profile helps maximize their visual potential, supporting learning, and improves overall quality of life. So first case would be a 3-year-old female child with neonatal hypoglycemic seizure and cortical visual impairment. MRI showed hypoglycemic ischemic encephalopathy and MEM was plus 0.75. The child had hyperopic shadows post cycloplegic refraction. Child had visual inattention and poor fixation to near objects. So here the child is seen to have poor fixation. When Lia paddles were placed in front of the child did not have fixation. While the child was given plus glasses, the child had better fixation for the Lia paddles since the accommodative insufficiency was addressed. So children with cortical visual impairment often have difficulty with visual attention and maintaining fixation, visual fatigue when trying to focus near objects, and associated accommodative insufficiency. So in plus classes reduce the accommodative demand on the eyes, making it easier for the children to focus on near visual tasks, thus enhancing attention, comfort, and visual learning. So next is a 5-year-old male child with delayed milestones and CVI with bilateral cystic encephalomyelitic changes. The child had lower field effect, poor depth perception, and spatial relation. The child is seen to have a large angle exotropia with 80 prism diopters of exo. The child underwent both eye squint surgery. So this is a preoperative video where the child had poor depth perception due to large exotropia, and the child was seen to have using the edge of the box as a touch clue to place the ball into the box, but difficulty to do it directly with visual perception. Here, post-squint surgery and therapy, now the child has better focus with a little improvement in the depth perception, and the child is able to focus in the near objects. So strabismus is a common in CVI due to poor visual attention, inconsistent fixation, or impaired binocular integration. Strabismus surgery gives better visual engagement after alignment, showing improved fixation, attention, and binocular visual field use. So when to consider surgery? When there's significant, constant, large angle squint in cosmetic and social concern, when there's a stable ocular motility, and after ruling out that improvement in visual function can be achieved by non-surgical CVI therapy alone. So case 3 will be a 2.5-year-old male child with regression of milestones post-septic shock and with delayed visual attention and tracking and poor eye-hand coordination. Here, the child is seen to have poor fixation for the objects and does not have eye-hand coordination, is not able to pick up the object. While here, when the child was placed on a position locked chair and a little bit of slant and good contrast in therapy, now the child is able to fixate with visual attention and the child has had improved eye-hand coordination. Children with CVI struggle with visual crowding and clutter. Increasing contrast simplifies the visual input. High contrast objects like black and white patterns or brightly colored objects on plain background, as shown in the video, stand out and are easier for the brain to process. This stimulates visual pathways, supports recognition, and builds visual attention. Repeated exposure to high contrast materials can improve visual fixation, tracking, and recognition over time. In conclusion, cortical visual impairment is highly heterogeneous, with every child showing a unique profile of strength and challenges. A one-size-fits-all approach is ineffective. Personalized intervention supports neuroplasticity and helps integrate visual skills into daily life. An individualized therapy empowers children with CVI to reach their fullest potential in learning, independence, and quality of life. Thank you.
Thank you, Dr. Shruti. Dr. Amrita, can you have your comments, please?
Yeah, thank you, Shruti. That was a wonderful presentation. This presentation was made just to show the importance of showing that each child is unique in its own. So we have to have a tailored approach for each kid. I'll just give you 3 take-home messages. That is, one is because there is survival of all the low birth infants because of the better NICU care, we do have an increase in the incidence of CVI with time. So we have to pay a lot of attention to these kids. And the most important thing is early intervention. That is what is missing in our country because the parents bring the kid very late. they'll just wait. Some parents, grandparents will say, or because the neighbors say, they say, okay, we'll wait for some more time and then start the therapy. So that's not right. So early intervention, we can expect a better result. And also, it's not only an ophthalmologist's work. It should be a teamwork of pediatrician, a vision therapist, physiotherapist, and the neurologist. So if we do it as a teamwork, definitely it gives a better result. And we should have a dedicated clinic, and we have to take enough time to deal with these kids. Thank you.
Thank you so much, ma'am. Manjula ma'am, is Menaka's video ready? Yeah.
Yes, doctor. Yes.
Yeah.
Shall I share now?
Yes.
Yeah.
Yes, doctor. One second. Is this visible, doctor?
Yeah, it's visible.
Yes.
Okay, doctor.
Menaka ma'am, start. You're on.
Is Dr. Menaka there?
The video also has an audio, I think, that can be played.
Yeah, it has a video and audio together, ma'am.
We're not able to hear the audio. Maybe you can talk along.
Okay, ma'am. Yeah, good evening all. I'm Menaka from Arvind Eye Hospital, Coimbatore. We'll be talking on subconjunctival intracameral intraoperative mitomycin C, a boon compared to the sponges. So mitomycin is used to salvage the blood. When it is used in the injection form, it can be used as small as 0.05 to 0.1 ml. It is given after corneal traction, 10 ml posterior to the limbus, and then the area is massaged with either muscle hook or the spatula over the intended scleral flap area for 2 minutes. If sponges are used, it is used after the peritomy. Then at the end of 2 minutes, it is carefully removed. And then washed thoroughly with balanced salt solution of 30 ml. However, longer duration of mitomycin is required for all the refractory cases, congenital glaucoma, neovascular glaucoma, uveitic glaucoma, traumatic glaucoma, and poor ocular surface cases. However, mitomycin, though it is a boon, it is not without the complications. Like it can produce a cystic avascular bleb leaks, hypotony, blebitis, endophthalmitis. Using an injectable form, the advantages are ideal blood formation, disposable of harmful mitomycin is not there. Ideal blood formation is elevated, less vascular blebs. It's not running, I think. The video is not running, ma'am.
I think we got the point. We'll have the discussion talk. It's very interesting. Who's the discussant for this?
Dr. Mrinalini, can you?
Yeah. Yes, ma'am. Good evening to all. As we know that MMC is commonly used to prevent cicatricial adhesions and enhance the trabeculectomy success rates. Though most of us are using MMC sponges during the trabeculectomy surgery, we just thought that we would highlight this technique, the shift towards the MMC injection. And this may offer advantages like a reduced surgical time, or it also gives a broader area of MMC delivery, and it also reduces the chances of sponge fragments. So that's what we wanted to convey. Thank you.
Very interesting. How long do you wait after giving the injection before starting surgery?
Yeah, we usually wait for 2 minutes, ma'am. Okay. That's a standard care.
And how are the blebs like, ma'am, post-op?
Yeah, we see a lot of like we see less cystic blebs, and we see more of diffuse and elevated blebs with the MMC with after shifting to injectable MMC. So definitely we are happy with the results. And also a study from Arvind Tirunelveli also showed a great success rate with when they compared it to the sponges, the injectables showed a higher success rate.
Thank you.
Thank you so much, madam.
Thank you. Thank you.
Can we have the last presentation, Dr. Vidya?
Janani's presentation is there.
Yeah,
Janani,
there is some
Janani,
technical
are you ready?
snacks and.
Yes, ma'am. I'm ready, ma'am.
Yeah, you can start.
Yeah.
Vidya.
I'll do it, ma'am, or Dr. Janani will do it.
You finish.
Whoever's ready can do it.
Okay, I'll just try just a minute.
Yes, Dr. Janani, please start.
Yes, ma'am. So, good evening. My topic is on dealing with hypertonic following trabeculectomy in iridocorneal endothelial syndrome. A 40-year-old lady presented with gradual painless progressive diminution of vision in both eyes, right eye more than left eye for the past 2 months. She was told to have no problem in the right eye and was given 2 topical medications. There was no history of steroid usage or ocular trauma or blindness in family. Ocular examination, she had right eye 15-degree exotropia, extraocular movements are full and free. Visual acuity in the right eye was hand movements close to face, TR inaccurate in superior and temporal quadrants. And in iris, she was having iris atrophic areas present at 5 o'clock and 7 o'clock with peripheral anterior synecdoche. Pupil was showing grade 2 RAPD. IOP by GAT was 14 millimeters of mercury on 2 topical medications. Visual acuity in the left eye was 3/60, improving to 6/18. And our IOP was 14 millimeters of mercury, rest anterior segment within normal limits. Gonioscopy revealed in the right eye, she had closed angles and with peripheral anterior synecdoche in all 4 quadrants. By the left eye, she had open angles. And fundus examination revealed 0.9 cupping with diffuse disc pallor in the right eye, while in the left eye, the cupping was 0.4 and neuroretinal rim was healthy. And OCT RNFL, the poor signal strength was there in both eyes. And CCT in the right eye was 544 microns and left eye 532 microns. T fields 25-2 in the left eye, she had high fixation loss. The diagnosis is right eye iridocorneal endothelial syndrome of essential iris atrophy variant with glaucoma. Patient lost to follow-up for 5 months and she stopped the medications. Came back with IOP of 32 millimeters of mercury in the right eye. Right eye trabeculectomy with mitomycin C was done on 26 July 2023. On post-op day 1, her IOP was 6 millimeters of mercury, Seedles negative, diffusely elevated bleb, and AC was formed, and there was no evidence of choroidal detachment. On post-op day 5 and 10, IOP was not recordable by GAT, Seedles negative, diffusely elevated bleb, AC was formed, and 360-degree peripheral choroidal detachment was present, and she was on oral and topical steroids and atropine eye ointment. On post-op day 24, IOP was not recordable by GAT and 360-degree CD was still present. Posterior subtenon triamcinolone was given 0.5 ml of 40 milligram per ml was given. On post-op day 45, the GAT was 8 millimeters of mercury and there was no evidence of choroidal detachment. Coming to hypertonia after trabeculectomy in patients with eye syndrome, it can result from aggressive filtration due to abnormal sclera and thinner conjunctiva, making the filtration more unpredictable. Due to abnormal wound healing response because of defective extracellular matrix regulation. And ciliary body shutdown can happen because of chronic synochial angle closure. And also judiciously use of antimetabolites should be used. If not used, that can also lead to thin avascular bleb. So normally posterior subtenons triamcinolone is used to lower the IOP and improve trabeculectomy success rates. But in our case, we gave a trial of using the side effect of the drug, that is increased IOP, to at least maintain the glow contour in our patient who was having a guarded visual prognosis. Thank you.
Subhashini ma'am, can we have your comment?
Yes. Janani, good presentation. So this case was presented just to highlight the management of hypotony following this classical case of ICE syndrome. Actually, because the patient was non-compliant and had high pressures, so despite poor vision, we thought we would do a trabeculectomy. But then we were expecting a bleb failure or something like that. And then we, in fact, used injection mitomycin 20 microgram. But in the post-op period, the patient went into hypotony. There was no bleb leak and the chamber was very well formed. And choroidals were there. So normally you get bleb failure mainly because of in eye syndrome. Actually, the endothelial membrane, it goes and clogs the ostium also. And in 50% of the cases, we have to shift to GDD. But in our case, and in GDD also, the tube can get occluded because of this endothelial membrane. But in our case, it was on the contrary, a hypotony which occurred. So we are not sure because of the abnormal healing response or the thin sclera. So, or it's because of mitomycin, though we used only 20 microgram in the injection form. The choroidals they did not resolve, and the hypotony also we thought it would become better, but it didn't resolve even with oral steroids and hiking up the topical steroids. So that is when we decided that why don't we try the Subtenon's injection? And there are anecdotal case series of using Subtenon's triamcinolone for resolution of the choroidal detachment. So we used in this case, the choroidals disappeared, and the IOP, which was unrecordably low, it reached to around 10 mm mercury. So the use of Subtenons in hypotony is the main highlight of this presentation.
Thank you so much, ma'am. If you have a shallow AC with choroidal, can we go for a viscoat injection?
Hello?
If you have a shallow AC with the choroidals, can we go for a viscoat injection?
The AC was shallow. No, she wants to know whether viscoat can be used to form the AC.
No, the AC was not shallow at all. The AC was, antechamber was well formed from day one. It was just the hypotony, whether it was a ciliary body response to the mitomycin, we do not know. But the chamber was very well formed.
Yeah, there was no cyclodialysis cleft.
Thank you.
There was no cyclodialysis cleft or anything which could have happened.
No, the UBM also did not reveal anything like that. So there are some reports in eye syndrome that hypotony can be because of the scleral, the alignment and all that. So, but we are not too sure what was actually the reason. So we just tried Subtenons to help maintain the globe contour, though she had poor vision in that eye.
Thank you, ma'am.
I was also wondering the AC might have been shallow and why you waited that long to give Subtenons.
Ma'am, can you come again? The network is...
Okay.
There's some technical snag, ma'am. The last 5 minutes, the network is poor. Can we have the last presentation?
Thank you.
Dr. Vidya. Thank you, ma'am. Thank you.
Yes, ma'am. I'm just sharing my slide. Just a minute.
We'll share, doctor. I will share.
Dear ma'am, on your camera, please.
Yeah. So this is a video. If it's not playing, I'll present as a PPT. Okay, I'll give the voiceover. This is about a disc edema. It is a very gross disc edema. which turned out to be optic nerve head granuloma. This is a patient, a middle-aged female who presented with painless drop in vision in the left eye since 2 months. She had a history of contact of pulmonary tuberculosis from her son 32 years ago. Visual examination, the right eye was normal. Left eye, there was a mild reduction in the visual acuity. There was RAPD. Color vision was not extensively reduced, but she had a gross disc edema with extensive hemorrhages, hard exudates. She also had vitreous cells. With this angry looking disc and, fields were non-specific defects in the right eye. Left eye, she had peripheral constrictions. The disc edema and the with cells, we thought she had inflammatory pathology. The ultrasound was done, which showed an elevated optic nerve head with localized retinal detachment. We were suspecting optic nerve dysfunction, but to a surprise, on the MRI, the optic nerve signals were normal, but she had only thickening of the left chorioretinal layer. With this, we suspected her to have optic nerve head granuloma. With this as a background, we further investigated her. She was found to be positive for Monto, QTB, and IGRA. HRCT test was normal. She was planned a course of systemic steroids followed by ATT, but ATT was deferred by both the ID specialist as well as the pulmonologist because they felt it is not an active disease and there was no role of ATT in her. We periodically followed her up. At 1 month, there was a reduction in the disc edema, but not very significantly. 3 months later, there was reduction, but still the disc edema was persistent. We know that the longer the disc edema persists, higher is the chances of permanent visual impairment as well as optic atrophy. So we went ahead and decided to give her a course of ATT without ethambutol. And we followed her up and we saw that she had a significant reduction in the disc swelling as well as improvement in the visual acuity and fields. So after 1 long year, we can see that her disc edema has subsided in the left eye with very good recovery of the vision. And that was the course of the disc edema of 1 long year. Moving on discussion, we know that tuberculosis can manifest in the optic nerve as a tubercle, papillitis, optic neuritis, or neuroretinitis. Optic nerve granuloma in TB is rare but not very uncommon. TB poses a lot of challenges because the negative or the antigen is usually negative, and improvement with ATT is usually used as a retrodiagnostic tool for ocular tuberculosis. So this case highlights a case of optic nerve granuloma in a patient with latent tuberculosis, which seemed to resolve relatively faster following initiation of ATT. The gradual resolution of disc edema supported a possibility of tuberculosis. What we're wondering is, did the resolution of disc edema in this patient, did it follow natural course or did ATT really help? With the contact history of tuberculosis and tests for latent tuberculosis such as Monto, QTB, IgR all being positive with no active evidence of tuberculosis, should we have initiated ATT at the beginning itself?
Thank you, Dr. Vidya. This case was targeted because we have a lot of patients coming to us with a non-resolving disc edema with a vision loss. Thankfully, this patient presented to us in the early phases where we were able to pin down the atypical appearance of the optic nerve head with a lot of exudates and a massive edema. Being in India, we all are exposed to TB bacilli with the BCG vaccine, so we may not rely too much on the mantle testing. But HRCT negative and an AGRA being a positive gives us in a fixed position. And anyhow, clinically, the patient had a inflammatory appearance with a choroidal thickening as well as a MRI showing a negative optic nerve signal, again warranting against a demyelinating spectrum. So we are giving more importance towards inflammatory. So what if there is an optic nerve involvement in the absence of an uveitis? Yes, it is really a difficult challenge for us to pin down that it is a TB association. But when there is a uveitis, when there is a exudate, when there is a wit cells, yes, there is always room for us to prove with the history of contact. So this patient had a very chronic resolution of disc edema, which is something which we have to be very careful because when there is a chronicity in the pattern of the resolution, we always think all the differentials because she is always something middle-aged. So you have to keep in mind even as simple as a masquerades also because the vision is not improving. But this patient responded very well to the steroids later phases after adding an antituberculous therapy. So we had to present this case just to reinforced that we are living in India and there is always a possibility of a latent TB manifesting, but do not escalate to the next level of immunosuppression without ruling a TB. Thank you.
Thank you so much, ma'am. So that's we come to the end of the session, and thanks to all the speakers for the amazing presentations. Yeah, there were some technical snacks, but that's usually common in Zoom meetings. So thank you so much to all the speakers and the chairperson and the co-person. Over to Sujata ma'am for the concluding remarks. It was a nice 360-degree coverage of all the subspecialties, and the moderators gave so many clinical pearls in this, really useful. Sujata ma'am and Vasudha ma'am, your concluding remarks.
Thanks a lot, Dr. Vasantha, Dr. Sharmila, and the host of speakers and the moderators. It's been a wonderful session, a lot of learning, and I hope all the postgraduates who watched this session would have benefited from this. Though it dragged a little bit longer, it was still very interesting. Unfortunately, because of the technical snacks, it got extended by another 20 minutes. But anyway, we could sit through it because of the interesting presentations, and the discussions were also very, very good. Maybe next time we will choose only 6 speakers instead of 13 speakers, so that we have more time for discussion. And thanks a lot. Ma'am, your concluding remarks, ma'am.
Yeah, usually I go to bed by 9:15 or 9, maximum 9:30. But
okay, sorry, madam.
The cases were so interesting that I'm not feeling sleepy even now. Okay, those who didn't attend this session are the losers.
Yes,
it was simply wonderful. Thank you so much to all the speakers.
Thank you, ma'am. So thanks a lot, and thanks for everybody for the coordination and the excellent teamwork. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you, ma'am.
Thank you,
Good night, ma'am. Good night.
Thank you, madam.